This is Chandrasekhar. I'm at Wayne State University in Detroit, Michigan. I was requested to run this session, so to speak. And we have Dr. Wiederhold, as you can see on the screen, has a presentation up there. So he's going to have a few slides, give his presentation, after which there will be an open discussion where anyone wishes to ask any questions, any topics you want to bring up, please feel free to bring up. We'll have an open discussion for about 20, 25 minutes. Dr. Wiederhold, please proceed.
Oh, thank you. And so what I was asked to do by the organizers of the symposium is just give a very, very brief overview of what we do in the fungus testing laboratory. And so, and then as mentioned, we would just kind of open up the discussion for anything in my presentation, or if folks wanted to discuss questions from other presentations, I would just kind of make it into an open forum, if you will. All right, so the fungus testing laboratory here in the Health Science Center in San Antonio was established in 1985 by Mike Rinaldi. Several of you might remember Dr. Rinaldi. If you ever heard him give a presentation, you probably have not forgotten it, or at least his style. It was very unique. We are a mycology clinical reference laboratory. We perform antifungal susceptibility testing, fungal species identification based on classic morphology and phenotypic means combined with DNA sequence analysis. And recently, we've also implemented Molotov mass spec. And then also we have a chemistry component with antifungal therapeutic drug monitoring. Our research mission is basically the same as the clinical functions and what we perform. We've often been involved in preclinical, clinical, and post-marketing studies that have been sponsored by the NIH as well as industry. And then also highly involved in training residents, graduate students, had numerous visiting scientists throughout the years, as well as been involved in international workshops and courses. And of course, being a laboratory, we're highly involved with several other schools and departments within our institution. One of the things that I think we always get excited about in the laboratory is when we are able to identify a brand new species of fungus that is associated with infections in both humans and animals. This can actually be quite challenging at times, but very rewarding when you're able to describe and publish a brand new species. And I've kind of given some examples of ones that we've done, at least during my tenure as director of the fungus testing laboratory. Then to kind of wrap up, one of the other things we're highly involved with is with antifungal resistance and surveillance. This has included individual case reports of resistance in different Candida species, such as Candida glabrata, as well as in Candida auris. And then most recently, some of our larger antifungal susceptibility surveillance work, specifically looking at the order Mucorales, and most recently within Aspergillus species within section Fumigati here in the United States. So with that, I'll conclude, and I think we're kind of at the point of opening this up for just an open forum discussion. Did anyone have any questions with regard to what we do in the fungus testing lab, or perhaps with the presentation that I had just finished up?
Okay, Dr. Wiederhold, can you hear me?
I can.
Great. Maybe I will ask the question first. Hopefully others will follow. Had a patient recently with disseminated fusariosis. This was a transplant patient who happened to develop a stem cell transplant 2 times. So profoundly immune compromised. Patient had engrafted, so no longer neutropenic, and happened to come in with fevers, pulmonary nodules, and right eye visual impairment. All of them turned out to be fusarium. Species have not been identified as yet. So we received the susceptibility data, and we found that it was resistant to amphotericin B, azoles, all of the drugs that were tested. Would you have any recommendations from the laboratory standpoint in terms of reliability of antifungal susceptibility testing to clinical interpretation as far as fusarium is concerned, and the possible introduction of terbinafine in this setting?
Sure. So fusarium infections can be quite challenging, as I'm sure you're aware. Interestingly, there have been manuscripts published within the last year or so that actually have shown a lack of a correlation between the in vitro susceptibility results and clinical outcomes, specifically in patients with fusariosis. And so based on those, the guidelines published by the European Confederation of Medical Mycology in collaboration with other groups for rare mold infections, of which fusarium was included, that came out in last year, actually do not recommend susceptibility testing for making individual decisions on patient care. Instead, what they recommend, if possible, is to treat with voriconazole. Now, oftentimes we do get requests for testing of terbinafine in our laboratory, but unfortunately, we have not really seen a benefit with those requests. Alone, terbinafine MICs are often elevated, and even when we test in combination with voriconazole, at least in our hands, we rarely, if ever, see what might be interpreted as synergy. Now, in patients, of course, who are failing therapy, especially if they've are already no longer neutropenic, then one suggestion that clinicians might consider would be to see if they can have their patients enrolled in a clinical study. There are a couple of investigational agents, such as alorifim, which has activity against certain fusarium species, not all of them, as well as fosmanogepix, which used to be made by a company called Amplex, but is now been bought out by Pfizer. And they do have studies in which they're enrolling patients as well as compassionate use programs. And so in those very difficult to treat patients, such as the one that you described, that might be worth a while looking into.
Thank you. Thank you. You can check the chat box. Has your lab turnaround time been affected by staffing issues? Our regularly contracted reference lab has experienced this, has horrible turnarounds. Dr. Wiederhold?
Our laboratory has not. We have been fortunate and not to have been hit as hard by COVID as other laboratories have. I know this is a issue that is occurring throughout the US, and my suspicion is that it's occurring in other parts of the world, specifically during the periods of surge that might be occurring in those different geographic areas. We have had some delays in turnaround time due to that, but luckily it has not been what I would deem to be a significant issue for us.
Yeah, this has been a problem at my center where I am. Overall turnaround time for most of the tests are being delayed primarily due to staffing following COVID problem. Dr. Luck, you want to unmute yourself and you want to say anything further on this issue?
Hi. Yeah, sorry. Wasn't in a place where I could talk. Yeah, I have a patient with what I suspect would be a phaeohyphomycosis, a transplant patient, and our lab couldn't identify the mold on culture with our MALDI-TOF and was sent out. And before I had any kind of input, it was sent to LabCorp, and they told us their sequencing results come back now 14 to 30 days, and now it's been about 40 something and counting. So it's quite atrocious.
Yeah, the identification of molds can be quite tricky, especially, MALDI-TOF has had the promise of improving turnaround times. And in some cases, I think that can be seen. However, if it is one of the more rare molds and it's not in the MALDI-TOF database, then the laboratories will have to revert to another method. Morphology probably is no longer an acceptable technique just because of all of the advances in the molecular assays and DNA sequence analysis that have really shed light on just the variety of different molds that can cause infection, and as well as the overlap in morphologic features. Where we see a long turnaround time for our mold identifications, which we still all do by DNA sequence analysis and try to make sure that that is, when possible, in agreement with the phenotypic characteristics. If it's a very rare species for which there are few, if any, deposits available within GenBank or other repositories. And so in some of those instances, especially if we're trying to see if it's a brand new species, the turnaround time can be quite long. We try our best to provide preliminary reports, of course, if possible, to at least get to the genus level, hoping that that might be able to guide clinicians. But we definitely have issues where even a genus level identification is not even possible, even by doing DNA sequence analysis. And so it can be quite challenging at times. If I may, one of the other things that we've seen, and going back to the previous question with regard to turnaround time, now, from our laboratory standpoint, we have not had a major issue, but one of the things that we've noticed, and this is now almost becoming a chronic problem, is the time it takes for couriers such as FedEx and UPS to get packages to us that contain the specimens. So it's not just a turnaround time from a laboratory standpoint and all the issues that COVID has presented to different laboratories, but for laboratories as ourselves that receive specimens from outside institutions, our turnaround time is sometimes also affected by delays in receipts due to problems that couriers are also experiencing because of COVID and other issues.
Yeah, our lab director has also complained about obtaining raw materials for the lab many times. It's in short supply and they're awaiting these materials to come from overseas.
Yeah, I definitely would second that. We've definitely had issues. Pipette tips have been a major challenge over the last year. It seems to at least be improving somewhat in that area. But the unfortunate thing is you never know what lab supply is going to be next in short supply. So it's very, very difficult to plan ahead.
Yeah, in Detroit, many of the large hospital laboratories are kind enough to share their supply. where places are in real need, the other labs are willing to share their supply very kindly. So that has alleviated the problem to some degree. Let's go to the other issue, Dr. Wiederhold, if I may ask, about the carriers testing and the metagenomic sequencing. I was contacted, besides carriers, carriers is only doing the test in blood or serum, if I understand correctly. I believe there are a couple of other companies that are doing it also in tissue samples, the metagenomic sequencing. What is your overall take on this, and how do you see this is going to proceed in the near future?
So my overall take is that this is a very promising approach, or at least it has the potential to really be a game changer in terms of the diagnosis of different types of fungal infections. That being said, I think there are a lot of challenges that lay ahead. There currently, Carius is definitely one of the bigger players in this market. And there are other companies, as you have said, that might be doing it in either tissues or other biological fluids, where Carius, I believe right now, is only accepting plasma. Several of the challenges that exist are, how well will this method, this metagenomic method, work in different patient populations? I think one of the slides that I had, I listed several different questions that remain to be answered, including, do you develop this within your own lab? Do you send it out to reference or commercial labs such as Carius? When do you use it? When all other techniques have failed, or right up front? How do you interpret the results, especially if you get multiple fungi back, and some of them are ones that you were not anticipating? They're supposed to be doing threshold analysis to try to determine what might be a real infection versus contamination or residual DNA, but no one truly understands what that threshold might be, or if it will be different based on the patient population or even the different type of invasive fungal infection. So there are a lot of challenges that lay ahead. In addition, at least from the Carius standpoint, my understanding is that it's not an inexpensive assay. And so laboratories are now having to deal with requests from clinicians to send out specimens that they have within the laboratory to Carius. And then the question becomes, who pays for that? Is this something that can be billed to insurance, or is this something that the laboratory themselves are going to have to eat the charge for? And so it's, again, it's a very interesting technology. From the Carius platform, where they use plasma samples, it is one of the big advantages is that it's non-invasive. So if you can make a diagnosis simply based on a plasma sample, that's great. But there are numerous other obstacles that have to be overcome in order for this to be more widely used for the diagnosis of invasive fungal infections. But not only for invasive fungal infections, I think these issues will also need to be tackled for bacterial infections as well as mycobacterial infections as well.
Yeah, absolutely. We're going through the same thing right now, as I'm sure many others on this call are. We just had a diagnosis of West Nile virus detectable by metagenomic sequencing in a patient. And this is, again, handled by the same company. And they charge about $700 to $800 for each specimen. And like you said, they get hung up on threshold values. And frequently they call the clinicians for discussion to interpret the threshold values, because they see multiple signals on these single specimen, and to interpret the multiple signals in a semi-quantitative way, they begin to rely on clinical data. So it's not black and white. There is a tremendous amount of gray area in final interpretation of these results. So we have established at our own institution, we have established a little committee consisting of ID person, the lab director, and another clinician to see if a case is justified to submit a specimen to carriers. Because it is expensive, and carriers representatives are directly contacting various departments, and the departments get pretty impressed by this information, and the number of requests to the lab has gone up tremendously, and frequently the labs have to eat the cost. So this has become a major problem, and I'm sure other physicians and clinicians are facing the same problem.
Yes, I've heard the same exact stories at our institution as well as others. The direct to clinician marketing that can be done. It's very interesting because I also have a pharmacy background. A lot of the issues facing laboratories right now in terms of the laboratory utilization committee that you mentioned, the direct to clinician marketing that companies will do. A lot of those things have been occurring in pharmacy with your antibiotic or the your P&T committees, the marketing by pharmaceutical companies directly to clinicians versus through the pharmacies. And so there are a lot of parallels between the laboratory and pharmacy that are going on right now. It's going to be very interesting to see what solutions come up from a laboratory standpoint, and if they might be different from what other departments within healthcare institutions do.
Absolutely. Thank you for that discussion. Does anyone else have any other questions or comments?
This is Vishnu Chaturvedi in New York. I have just a related comment, and possibly some of you will express your opinion. I think in addition to the utilization, or along with utilization, it's not just semantics. I mean, what we need is a laboratory stewardship committee, because the interested parties are in different silos, and sometimes they're not talking, and not all good practices are out there. And so I will now stop and see if you have any comments on lab stewardships.
Oh, I absolutely agree with that. I definitely think there needs to be a lab stewardship committee, just like there is an antimicrobial stewardship that's now widely accepted and basically required at healthcare institutions. And so I think from a laboratory standpoint, that makes perfect sense. I know here, at least at University Hospital here in San Antonio, they've already started to implement such a stewardship policy with regard to laboratory tests.
Yeah, I second that. We in Detroit as well, we have a laboratory stewardship meeting once every few months, headed by the lab director, run by the Department of Pathology. And then there are representation, many from the clinical side, as well as from the lab side on various issues. Because many of these companies are putting a lot of pressure on the lab personnel, as well as on the clinical side to bring in their laboratory tests. So to avoid overuse or misuse, this kind of stewardship meetings have become very important.